Hi, everyone.
Hello, Steve.
Hi, Steve.
Sorry, I'm a little late. Well, welcome, everyone. Has someone done the introductions yet?
No, not yet,
Yet.
Steve.
Okay. Well, welcome. We're really appreciate so much everyone joining in to listen to the presentation for our students. I think our first taste of this was terrific, and I'm sure that it will be similar for the other students. You know, I want to once again give my appreciation for Cal and Peter and PK, who, despite the ban on travel, were willing to step up and fund the past year's projects for students. We really appreciate that. There was also a Rotary Club that did this. So I think we should just start so we don't end on time with our first presentation. And I'm sorry, Desi, I don't have the list, but could you introduce the first people?
Yes, of course. So the first person who's going to present today is Emily. Her project is called Inaugural Data Analysis for the Colorado Haiti Project.
Hi, that's me. So hopefully this will go up okay. Let's see. So if I can share my screen. Just a second. Okay, are you guys seeing my screen okay?
No.
Not yet. Okay, I'm so sorry. Let's see. This guy.
There we go. Terrific.
Okay. Okay, so we can see everything? Perfect.
Yes, it looks great.
Okay, great. So my name's Emily. I'm presenting on a data analysis that we did for Colorado Haiti Project. So I just wanted to start by giving a brief history of Haiti as it relates to some of the chronic struggles that they face which in turn relates to the work that Colorado Haiti Project does. So Haiti is a small mountainous country about the size of Maryland. It's located in the Caribbean and shares a border with the Dominican Republic. It had a population of about 10 million in 2016 and has a geographical area of 27,000 square miles, including 2,000 miles of coastline. So prior to gaining its independence in 1804, Haiti was under French colonial rule, during which time the native Taino people focused heavily on forestry and sugar farming, which led to severe land degradation that would have many consequences for years to come. So since gaining independence, Haiti's been plagued by political strife, unstable leadership, and horrific natural disasters. In 2010, Haiti was struck by one of the worst earthquakes in the 21st century. Over 300,000 people were killed and more than 2 million people were displaced from their homes and communities. And before being able to fully recover from that, it was assailed by two concurrent disasters in 2016, a drought caused by a prolonged El Nino, and during the same year, Hurricane Matthew struck, bringing with it flooding, landslides, infrastructure decimation, and the loss of agricultural crops, with more than 50% of that damage occurring in coastal farming communities like Petit Trou. So these areas lost 90% of their crops, their clean water infrastructure was destroyed, and vaccine cold chain programs were crushed. Haiti has also struggled with food insecurity, with more than 40% of homes experiencing some form of undernourishment or chronic malnutrition, which is inflamed following the disasters of 2016. So you can see in this map the area that Colorado Haiti Project serves, which is Petit Trou. It's a small coastal farming town, approximately 59 square miles in size, and it has an estimated 32,000 people. it, like many such towns, struggles to maintain its population as young people often leave for more opportunities in the capital or even outside of Haiti. So Colorado Haiti Project seeks to empower community leaders with tools and funding they need to make Petit Trou an area of opportunity and a place where it's sustainable to stay and raise a family. So it was founded in 1989 by Episcopal priests both here in Colorado and also in Haiti. Over the course of its 30-year history, Colorado Haiti Project has really transitioned from a missions-based direct service program to program implementation, at the local level. So despite that, though, its knowledge of its service area has really remained limited, as has the epidemiologic and demographic profile of the entire country as a whole, in part due to the recent climate disasters Haiti suffered. So Colorado Haiti Project has developed a multitude of programs within its service area, all aimed to combat different challenges that Haiti has struggled with throughout its history. So you can see on the map, the creation of wells, the seed banks, and where community health workers are clustered. So my project was really aligned with the goals of the community health workers, which was learning more about the area that Colorado Haiti Project serves. So goals for my project with Colorado Haiti Project were to help them take the data that they have, limited as it is, and transform it into something that's usable for them moving forward. So after working with Colorado Haiti Project, it was determined that the best format for them was to have a Google-based or Google Sheet-based database. And this was determined to be the ideal solution for them, as it would enable them to access the data easily and use it moving forward without having to learn a new system or house it somewhere kind of clunky or in an office when they're working remote currently and may be doing so for the foreseeable future. So we also thought the creation of a single access database might be useful as a data repository, but that could be stored in the office and only accessed when new reports were generated, just as like a home for those. So as part of this project, we ran into a few stumbling blocks along the way, both in terms of the data itself and what it could be used for, as well as the creation of the database. So first and foremost, apparent struggle was the nature of the data. So in terms of formatting, all the data that Colorado Haiti Project receives from these community health workers, as well as the clinic, are in the form of Word documents with complex tables. So this issue became apparent pretty early on in my project, and I came to realize the struggle that Colorado Haiti Project really has and encountered with keeping current with this data. So they really rely on volunteers and students like myself to make use of this data. So this causes a lot of starts and stops for them in their functionality, often leaving them with partially finished projects and no further along in really understanding their own data. So as a result, I wanted to create a streamline the process of report collation into this database that I was going to make for them, so that it can be utilized even after I'd finished my project. So my partner actually works in software development, and through talking with him about his work, I came up with this idea of creating a tool that would read these Word documents and translate them into this Excel-based or Google Sheet-based document and lay it out in a manner that Colorado Haiti Project could use. So this program can pull and translate a single month report, as well as collate those reports into a larger database, either for 1 year or across years. And this became the focus of my project, to deliver to Colorado Haiti Project a sustainable tool that would allow the database So this had its own struggles, both stemming from my need to learn some very basic aspects of Python, as well as to create the program from the changes in report layouts that had occurred over the years, as well as delineating what each section was actually telling us. So that was a good portion for our project. So this is kind of an overview of the steps taken throughout the course of my project here, which I'll go into more detail as we move along. So this is what we started with. It's just these Word tables that are 3 years worth of disaggregated monthly clinic reports that were based in these Word documents with formats that had changed over time. And they had a potential to tell us a lot about the community that Colorado Haiti Project serves, but the way they were structured left a lot to be desired. So what I did originally was figure out essentially all the reports that they had, found any missing reports that they essentially had or needed, and then work to acquire those from the clinic. And then once I've gotten all of those, we created a shell or Google-based or Google Sheet-based structure that Colorado Haiti Project wanted to use moving forward. So that can be seen here. This is just like the shell of the sheet that my program would then put everything into. And so here you can see this kind of process of how we got to where we are. So we take the word tables, then it would run through my program and then output into these sheets. So it's a synthesis of kind of all of these steps. So we began with the word tables, run them through the program, have them output into that shell, and that way they can visualize the tables and the data over time versus just independently on one sheet in a way that wasn't really usable for Colorado Haiti Project. So all the steps in that previous slide are run by these two small folders here that you can see. So in that, with help from my partner, we house the data streamlining tool that I created. So this is an important step as it really allows the tool, which runs along the command line, which I find a little bit intimidating even still, to be run with just the click of a button. So the first is designed to run for each month individually, and then for ease of transfer of data to that access database that I talked about as a repository, whereas the secondary program is essentially the same information in the first, but designed to output across a year rather than a month. So these can easily be modified to create sheets spanning multiple years if it's desired, but we had originally with Colorado Haiti Project decided that a year was probably as big as we wanted because we didn't want these sheets to become too unwieldy. And then following that, those sheets can then be utilized to put that information into that access database that we were talking about. We also created a step-by-step instruction manual on how to use the access database and put it in, as well as a data dictionary that said what each term is referring to so that it was very clear. So, okay. And then in order to visualize the data, I took those created sheets that we had output, that database, and then cleaned them in SAS so that I could use them in Tableau, which was a personal goal of mine for this project. So this too took a great deal of time, but it was an important step in gaining that baseline understanding of the data. So after I was able to get the data into that workable format and clean, I was then able to transfer it to Tableau. And here's where we took the first ever look at this data. So I spent some time really getting a sense of who was being seen and for what reason at these clinics. And then also who was being seen within the community health or by the community health workers. So this first one is just a breakdown of who is being seen in the clinic for both subsequent or first visits and then for subsequent visits. And in this subsequent one, there's a large area, it says PF client. For that, it's people seeking contraception and sexual health needs. We were also able to break it down by the proportions of children being seen for the first time by age, as well as by sex. So here the shading is alluding to the numbers being seen, while the size of the box is referencing the proportion that makes up for the demographics. So the three darkest boxes are just total children being seen by age. So 0 to 6 months, 6 to 24, and then above 24 to 59. And then the other three groups are that same information, but then broken down by sex, so male and female. We were also able to get a sense of the numbers of children being vaccinated and where those vaccinations were being done. So this data is actually really crucial to Colorado Haiti Project, as it clearly shows that most vaccinations for both males and females are taking place out in the community and are therefore being done by the community health workers that Colorado Haiti Project funds. So that's the darker pink for the females being done within the community and the darker blue for the males being vaccinated out in the community. Okay. We were also able to break down when and how frequently women were being seen for prenatal care by looking at what visit they were coming in according to a period of pregnancy or trimester. What's really important to take away from this part is that even though there are a good number of women coming in for their first and second visits in the first and second trimester, there's still a really large percentage of women who are waiting until their third trimester to come in for their first prenatal visit, which shows us a potential area of investment to improve community health. We can also see here, this is the time delay of the between birth and then when that first home visit by a community health worker takes place. So the blue is the 0 to 6 hours, red is between 7 hours and 6 days, and then orange is the 7 to 42 days after birth. And what's really great here is that we can see the majority of those visits are really occurring in that 0 to 6 hour window, which is good data for Colorado Haiti Project with their community health workers. We're also able to delineate the causes of obstetric complications across years and compare where interventions may most be needed. This is the same data visualized 3 different ways of the types of complications and then broken down by year. We're also able to look at where births were occurring by age of the mother and take note that the majority of those unknown ages are occurring in the community rather than the clinic, which can tell us a little bit about where we need to improve data collection and the type of data collection that we need to increase for our community health workers. I know we're coming short on time, so I'll go a little bit quicker on these. We were able to see what treatments were given for pregnant women across years and when they were focusing on certain types of treatment, as well as family planning utilization services for women and contraceptives that were distributed across years and months. We also were able to look at the burden of chronic disease. So what was the biggest cause for this community, as well as malnutrition by age and sex, HIV by those same characteristics, the proportion of overall disease, so acute respiratory infections, you can see makes up almost half of their burden of disease. And then this one is showing the burden of disease just in a different way. It's broken down by demographic. So each color square here is a demographic, so age and sex category. And then the breakdown is type of disease. And I also have that in a final form right here, which I think is a little bit clearer. So each color in this instance is instead a disease, and then each bubble represents a demographic. So you're showing the burden on each particular portion of their population. And those are all of my things. Any questions?
So Emily, that was terrific.
There's a lot, sorry.
You know, you realize that being able to understand how to help these projects by being a kind of an IT consultant and figuring out a good way of doing it is just so important. And I think it's one of those areas where students can make a major contribution. How do you think the organization is going to use this data to improve services or modify, or have you gotten any feedback about that?
Yeah, we have. So we've talked about a couple things moving forward. So the way in which the data is collected is pretty much determined by the Ministry of Health. But there's been talks of requesting funding. So it wasn't in this particular one, mostly because there wasn't a lot of data regarding it. But birth weight for babies is really measured in clinic, but they have almost no data for the birth weight of babies born at home or in the care of a trained midwife at home. And so there's been talk of like requesting money or getting grants or applying for grants to use this data to be able to acquire essentially more data to have a better idea about community health and if there's a difference between babies born at home versus babies born in the institution in terms of birth weight. And there's also been talk about using the data, for instance, like I said, with the trimesters and when people are coming in for those first consultations, in doing more outreach efforts to get women to be seen earlier in their pregnancies rather than just in their third trimester. Hopefully that answers your question.
I know we're a little over time, but I just had one other question, and that related to head circumference. Do they collect head circumference, and did you do any analyses on head circumference?
There is limited data on it, so it's not something that's captured at every visit or with every birth, but I did not do any data analysis on it, mostly because there's very limited data.
Okay. Well, thank you so much, Emily. Let's move on to Rouna, Mohran on the effects of relocation to the United States on mental health condition of refugees and immigrants.
Yeah, so I'm Rouna. I'm a second-year medical student, and I am studying the mental health conditions in the Colorado immigrant and refugee population. So let me just share my screen here. Okay, can everyone see that?
Terrific, yes.
Okay. So like I said, my name is Mohran. I'm a second-year medical student, and my project is on mental health conditions in the refugee population. The members of my team, so this project was of my own design. Dr. Madiha Abdul Maksud is my project mentor. We've been working with the refugee health team at the Colorado Department of Public Health and Environment, led by Lori Kennedy and her team. And I'm also working with a global health student at the CU Anschutz campus, Nicole Petrovic. She's been very helpful so far. So this project was entirely local. All the data that I've been using was collected from clinics and refugee patients who have been in the Denver metro area. So the particular question here is, what is the association between immigration status and country of origin with the prevalence of mental health conditions in the Colorado refugee health population? So just as a little bit of background, every refugee who enters the United States has to undergo this domestic medical exam within the first 90 days. Only 7 states in the United States conduct these exams. Colorado is one of them. So during the DME, they'll collect demographic data such as age, gender, what their race and ethnicity is, what their country of origin is, and then also a medical history, what kind of immigration status they qualify for. And so from 2014 to 2019, which is kind of what the population that we'll be using for our data is, about 8,000 individuals have been screened in Colorado. So these individuals don't have to stay in Colorado. A large number of them are screened here and then relocated to a different state. But of those 8,000 screenings in the last 5 years, that's kind of, this is the breakdown. Can you guys see my mouse? I think so, right? Yeah, so this is kind of the breakdown of where those immigrants and refugees are coming from by country. So as part of the DME, they also conduct a refugee health screening 15, which is the RHS 15. It screens for mental health conditions. So just to say it's positive for different mental health conditions, it's not a diagnostic screening. A large number of these refugees who have positive RHS 15 screenings are then referred to mental health clinics to follow up for those conditions. And so this is just a little bit of data that I pulled out. A lot of these studies are centered out of Europe. I didn't find a lot of studies from the United States, which I'm hoping to add to that literature. But as you can see, there's a prevalence of anxiety, depression, and PTSD, both clinically diagnosed and self-reported in these populations. And then they also differentiate based on the different immigration statuses. So in Moldova, there was the victims of trafficking, about 54% of them screened positive for some kind of mental health condition. And then asylum seekers and unaccompanied minors also have significant numbers. So this project is kind of trying to add to that and kind of center it in the refugees who are screened in the United States and specifically Colorado. So the methodology here, we'll be focusing, our sample size will be around 3,000, almost 400. So these are the immigrants who were screened in Colorado and had a positive RHS 15 screening. So this is an example of the RHS 15. It's 15 questions and the different questions correlate to the different mental health conditions, including adjustment disorder, depression, anxiety, PTSD, and substance use disorder. The RHS 15 is administered to anybody over the age of 16, and it's translated into several languages to accommodate for the refugees who are not fluent in English. And then we'll also be using the DME refugee data that correlates to immigration status, country of origin, and then also a number of comorbidities that we want to also control for. So part of the methodology, so we're running 2 independent analyses. One of them is immigration status and MHC screening, and then country of origin and MHC screening. So this is kind of a breakdown for what the different variables in those 2 classifications are. So immigration status includes refugee, asylum seeker, unaccompanied minor, human trafficking, special immigrant, juvenile, etc. And then this is again the breakdown from 2014 to 2019, the country of origins for the refugees who were screened in Colorado. And then again, just the positive screening for the different mental health conditions. So we'll be running regression analyses and controlling for those various demographics and comorbidities that we collected from the DME. So one of the biggest roadblocks that I'll talk about is that we haven't quite gotten the data from the CDPHE yet. So currently they're preparing that data and giving it to us in the next week or 2. I was really hoping to get that data before this presentation so I could at least run some preliminary analyses, but unfortunately that didn't happen. We have been confirmed to be comorb exempt. The project design is exempt for comorb. So I'm hoping to get the data within the next week and then run the statistical analyses by the end of March. And then I would really like to submit to the North American Refugee Health Conference by April, and then kind of prepare a manuscript and also to follow up on the project. I want to follow up with the refugees who were referred to those mental health clinics because of their positive MHC screenings or RHS-15 screenings, and see if there was any variation in their mental health from the time, well, first to see if they ever did follow through with those referrals, and then if their mental health has changed in the time that they've been in the States. So obstacles, the CDPHE has been really swamped with the COVID-19 pandemic over the last year, and their refugee team kind of got put on hold for a little bit. So accessing that data has been really rough, but we're kind of getting there now. And then also when I was talking to the refugee health team, they were kind of telling me that a lot of the supporting clinics who give their data to the CDPHE, some of them just have problems keeping their records. And so that'll be a future obstacle of just like the incomplete records that those clinics have. So acknowledgements, my project mentor, Lori Kennedy at the CDPHE, and of course the Robertson Durst Scholarship. And I want to thank you all again for this contribution, and hopefully we'll have some concrete data soon.
Rouna,
Thank you.
Sorry, Steve, I was just gonna say, because I don't think Rouna really explained how much effort she's put in trying to get the data, and the team is wonderful. The team at CDPHE, like she said, they're just swamped. So she's doing a great job trying to keep everyone on track here.
Steve, I think you're muted.
This is PK?
Yes, PK, would you like to say something?
Yeah, I was quite involved with a similar type of situation when I was the voluntary medical director for CAHEP, Colorado Alliance for it's public health, for refugees. So we used to, that was for about 10 years. We used to see almost like 23 different nationalities. The main issue, as far as I know, in addition to their medical problems, the main issue is mental health is the main issue these people have, because there's not only a huge change in their environment, but there's a major adjustment disorder, as well as depression, anxiety. And many of these people, especially countries like Myanmar, I saw hundreds of these Burmese refugees who basically have been driven out of the country. And one of the major issues that was they actually witnessed their own family members being murdered right in front of them by the army. And such types of actual visual type of pictures are such unbelievable role in their mental health. So this is a major issue. I wish that data would be presented next time, because this is one of the most important things that these people face. The other thing these people face is, I saw many people from countries like Iraq, sorry. And these were all professionals, attorneys, accountants, who were basically refugees in Denver, and they were working like in King Supers, in checking counters and keeping different like storing products after midnight. So this was a major change in the type of environment they had to face. So it's a huge issue, and I'm glad you are involved with it. And you will really, it will be sort of a eye-revealing, like eye-opener type of thing that might even change the way you look at yourself and your future once you listen to these people's stories. So I just wanted to share that it's a major, major issue.
Thanks, PK. Rouna, I just want to say, don't be too frustrated, because you're really learning something about doing research that's meaningful. And that is, it's a combination of passion and persistence. And I think that you have both from what Madiha is saying. And you just have to be persistent in terms of getting the data. And so often we run into the kinds of problems that you're describing. And don't be too frustrated and too disappointed. This is more common than not. And I think we all feel very good about your persistence and perseverance in getting the data. And we are really interested in the data. And when you get it and run the analysis, if you can send us the slides with it, we will distribute it to the funders and also people interested in this area. So I'd like to move on now, if that's okay, to the COVID virtual summer camp project with Evan and Boris. And I don't know how you're both going to handle this, but I'm sure you figured out how to share the time.
Hi, everybody. I'm Evan Cornish.
I'm Boris.
Hi, Ev.
Sorry. We had this whole spiel.
Okay, so can you all see my screen?
Mm-hmm.
Okay, fantastic. So first of all, thank you all so much for the funding from the Robinson Durst Scholarship. This was a huge piece of our project, being able to essentially offer our middle school students, our budding scientists, like a little bit of financial incentive for them to participate in this camp, which they all did very successfully. So some context, I know that it's very hard to remember a time before COVID, but there was. And last spring, all the Denver public schools went virtual. Obviously, all schools did for the most part. And what we didn't anticipate, though, was that this was going to be a loss of mental health resources provided by schools, or at least I didn't personally know that that was going to be a factor in school shutting down. But most students who access a mental health resource do so through their school. And obviously, it's much harder to have confidential meetings and so on if you're Skyping in or Zooming in from home. So there was an issue with increasing screen time for adolescents, increasing levels of anxiety in young adolescents, and there was really information overload. I think that we can all sort of appreciate that there's still information overload, but certainly last spring, even more so maybe. So they were receiving, information about COVID from their school, from social media, from the news, each obviously with a different level of veracity. But the point remains that there was a real sort of overload of information. And, Boris and I both had totally different research projects planned for last summer. Obviously they were no longer possible because they required us to be in person. And we had this moment where we're like, wow, like imagine if you were, 12 or 13 years old right now and how, brutal of an experience this has been for us. Imagine what it'd be like for them. So we thought, we are confused about everything that we're being told as far as data goes. We should, as part of, this idea that we had to offer some sort of supplemental education, include a curriculum about how to assess resources, how to, essentially tie down a fact to the publication from which that fact supposedly came. And we did this through a longitudinal curriculum. So part of what's taking place in the medical education reform right now is that we're moving toward longitudinal curriculums. We thought that'd be kind of interesting to test this out on a minor scale with regard to curriculum about, evidence-based medicine. We didn't call it that. We were trying to maintain the attention of 12-year-olds. We had these continuous threads throughout. So for instance, evaluating information found online, obviously actual infectious microbiology of COVID. And we also discussed health disparities. And then punctuated throughout these curriculums was Q&As with experts. So Dr. Abdel Maksud, who was our advisor, spoke. Dr. Overbeck, who works in the emergency department, spoke. We had Dr. Carter, who's a cardiologist, speak about the role of the microbiome in infectious disease as well as chronic disease. And then we had a discussion with an infectious disease doctor, as well as Dr. Butterfield, who is a psychiatrist and could sort of speak to the emotional experience of the COVID lockdown of that summer that we all went through. So the idea was essentially to inform these folks over a period of time and to get them engaged. So I'm going to hand this over to Boris in 1 second so that he can talk about the data. But one of the really interesting things that we were able to do, thanks to your funding, was have students take a questionnaire before or at the end of the first camp, and then at the end of the at the end of the first day, and then at the end of the last day of these camps that we ran. And essentially we wanted to see what their emotional, experience had been like, as well as what data, what information they were able to reproduce at the end of the week and what confidence they felt discussing that data. But Boris, in his infinite genius, had them also do these word banks and essentially describe their experiences over the last few months. And then he found a way to overlay this qualitative data onto axes. And I'm going to let Boris explain it.
Yeah. So yeah, like Evan said, the main thing we did was we put together this camp, and it allowed parents to kind of give their kids a chance to do something over the summer. I think kids were cooped up for a couple of months in their houses. And my preceptor, she's a pediatrician, and since January, I definitely saw not a huge, but definitely an increase in the amount of ADHD consults, depression, anxiety consults. So it's gonna be interesting to see like where this goes. But as far as the methodology goes, we delivered the material and we administered the survey before the camp and after the camp. And we asked them a bunch of questions, but we're just gonna talk about their knowledge, confidence about talking about COVID, and if they felt like, they could understand the topics pertinent to it. So regarding this, we saw an increase. So students felt like they walked away with some knowledge, which was awesome. And if you want to go to the next one, we'll do and then so regarding the word bank, we also asked them, well, what are your kind of attitudes, feelings and emotions towards this? You're grouped up, you're not allowed to socialize, whoever's finishing 8th grade, they don't get that opportunity, which is a bummer. But so we asked them at the beginning, okay, so how do you guys feel? And as you can see, the red in the top left, those feelings are associated with high energy, unpleasant. So things like, I'm anxious, I'm angry, I'm frustrated. And if you go kind of towards the green, it's low energy, pleasant, right? Yeah. Yeah, so things like chill, feeling good. So you can see the majority of the responses at the beginning of camp, they were pretty upset. It looked like, those, anxious feelings definitely came through. And there's the tally in the bottom left there. So the top panel is before the camp, and at the bottom, we asked them the same exact thing, but we asked after the camp, right? So we're going to tell you exactly what's going on. We're going to talk to you about health disparities. We're going to give you a gift card. How do you feel now? And, just like we would expect. So everyone keeps telling us the majority still stayed there. They're like, yeah, I know more, but this still is no fun. Yeah, which was cool to see. It's there's no significant shift, and we did a chi-squared thing for it, for the tally, just to kind of put some stats in it. But yeah.
So I think what, I think essentially the ability to take the words of students. So we have some like selected responses here. So for instance, everything that's underlined was chosen from the word bank here. And then they either just chose them, some folks just chose them, or incorporated them like into a larger statement. And then based on the ones they chose, we could then overlay that onto this pleasantness, unpleasantness, intensity axis. But I think this should not detract, though, I think, from the real quality of like what these kids said, or not kids, these young scientists is how we exclusively refer to them. But you can see that these are young adults, right? They're developing, I think, an impressive level of reflection about the situation. I think this is worth reading. So I feel enraged about the hysteria that came from apathy toward virus prevention. I'm concerned about the future of humanity if we continue this bitter behavior. I just think, for a 13-year-old, for a 14-year-old, I was very impressed with what these,
The prompt just said, use 5 words to describe how you feel, and some of them put it so eloquent, like they went above and beyond. So clearly, yeah, it was neat.
It was great. So we've had some success presenting this data at a few places. Again, all very much thanks to the funding that you all made available. We recently spoke at the Western Medical Research Conference, and we were the first speaker. That was really exciting. And then they published our abstract in the Journal of Investigative Medicine. We just were really very fortunate at the 35th Annual Student Research Forum, and we won in the category of medicine, which was really exciting. And then we also submitted a manuscript, and this is worth mentioning as well. So the Robinson Durst Scholarship was the last thing that Boris and I did as just Boris and I, as everything was sort of molding in the months right after quarantine began. Rouna sort of joined the team. She's an author on our paper, as well as a presenter at the conferences with us. Rouna, she also wrote a ton of the curriculum, so she's been a huge part of this as well. And obvious thanks to Dr. Abdel Maksud. Thank you so much for your guidance and helping us sort of get all this together and off the ground.
Rouna, you're a twofer.
It's true. It's true.
You get double credit, Rouna.
And
so what happened? How many people of the kids did you document? How many of them stayed involved over the whole time versus essentially dropouts?
That's an interesting question. When you say dropout, do you mean like for the entire, I'm sorry, I should have clarified some logistics about the camp. Do you mean for like one of the days of the camp, or do you mean like just logged in and then was away from their camera?
Well, how long was it? Just one session? How many sessions were they? And do you have any sense? I mean, what I found was when I lectured, half of the students kind of go off camera, and I have no idea whether they listened or not. So both of those questions.
Yes, absolutely. I'm sorry. I've had my we've been like in the thick of writing this manuscript and thinking about this for so long. I should have clarified like the basics of this project. So I apologize for that. Yes, so it was 2 camps. Each camp was 4 days. And we taught identical material in each camp. These were the first and second week, so the first and second and third week of July of that summer, the summer of 2020. And it was 4 days. So essentially on the first day, it was introductory information. And then by the end of the first day, they were already getting to ask questions of Dana Yabrudi, who is a medical student with us who experienced quarantine in New York. So the idea was like, I don't have data necessarily on whether or not folks were there for the entirety, but we did have breakout rooms where I think the majority of folks participated. I don't remember there being a ton of no-shows, however we want to describe that over Zoom.
So Stephen, can I make a comment here, because
Sure.
First, those guys put an incredible amount of work. I actually watched them lecture and how they simplified very important concepts to make them digestible for middle schoolers. That's number one. Number two, one of the main goals of these scholarships now, funders are listening to us, is sustainability. And this is not just one project and it's done to fulfill an academic requirement. All 3 students, Boris and Evan and Rouna, when I reached out to them and I said, why don't we just offer this on a continuous basis? Every summer we have a partnership with DPS and offer summer camps every summer, scientific camps every summer. They all were willing to mentor future students, whether medical students or public health students, to teach them how they did that so that we can continue to offer these camps. We're looking now, working with the leadership at the School of Public Health to just make it formally a practicum opportunity for our students. So this is much bigger than what Evan and Boris just presented. This is going to be sustained, and it's wonderful. They get full credit for starting this from nothing to where we all listen to today.
Thanks so much. Desi, are we recording this?
Yes, I'm recording, Steve.
Because I would like to send the recording of this. I know Mary's not on the call, but of the whole day and of Wednesday to all the Rotary clubs to try and get them to recognize that even though the students are not going abroad, that there's a lot of value in their projects. So if you could please remind me about that, I would appreciate it.
I remind you, Steve.
Any additional comments from Peter or Cal or PK or
Just to
anyone
swing back
else on
around,
the call?
so I found a number. So we have 85 surveys that we got between the 2 camps. So we had 85 at least. And then we reached out to the entirety of DPS, which was, I think it was a good number.
Yeah, I think you did a great job. Cal?
Yeah, I just wanted to echo what you just said, that I'll have to confess, I had some serious doubts about the value of trying to do a global health rotation here in the US. But what I've seen so far has more than dispelled any of those doubts. As a matter of fact, I think that the projects that you guys have done that we've seen so far have surpassed in quality many of the global health projects that we've heard reported in years past. Some of that I think may have to do with the fact that you have better mentoring and a broader pool of resources here than you might have in another country. But I see some real innovation. I see some really hard work, a lot of hours put into these projects that I just want to congratulate you on and thank you.
Thanks, Cal. Peter,
And,
would you like to have
yeah,
make a comment?
Yes, I echo what Cal and you, Steve, has said. I am so impressed with the flexibility and ingenuity of all you presenters to take what has been lemons and turn it into lemonade in these presentations. They are forward thinking and a wonderful model for future ways of doing things. And I am so impressed with each of you for figuring out how to do this so well in these times.
Thank you. Thank you very much, Peter. We've got one more, Amanda, who's going to talk about rheumatic heart disease, echocardiography training of nurses in Rwanda.
Hi, everybody. And the last one. So yeah, let me quick share my screen and we will jump right into it. Okay. Can you all hear me and see this?
Mm-hmm.
Wonderful. Okay. So yeah, let me just quick introduce myself. My name is Amanda Hunt. I'm a second-year medical student. And then my faculty mentor that I worked most closely with was Dr. Yihan Lin. And what I'm going to be talking to you guys today about is rheumatic heart disease care in Rwanda, and then echocardiography training of the local nurses. So to begin, I don't have any disclosures or conflicts of interest. I do want to say thank you to the Global Chest Initiative Scholarship, absolutely, for helping me conduct this research and these projects. It's been wonderful. And then Team Heart Rwanda, which is an NGO that I worked very closely with. So where I would have been traveling if COVID were not a thing would have been Kigali, Rwanda. And I would have been able to kind of experience the Rwandan Military Hospital, which is pictured here, and some other district hospitals. I would have spent a lot of time at the team research office in Kigali. And then I just wanted to put a note here about the languages spoken in Rwanda here. It's this very small little country. English, Kinyarwanda, and French. So a little background about Team Heart and the wonderful organization that I was able to be a part of. It was founded in 2005 by Sia and Chip Bowman. This is Dr. Bowman right here. And it was founded on the basis of a huge need for research and help with the cardiac burden in Rwanda, the cardiac disease burden, need for electronic medical records, prophylactic penicillin programs, training of local nurses and staff, as well as just expansion of the education on what, rheumatic fever is, rheumatic heart disease, what strep throat is in general. And this project and things have been in collaboration with the Rwandan Ministry of Health and Rwandan Heart Foundation. So the two asterisks are kind of the main programs and projects that I kind of spearheaded over the summer. So we'll dive into those. So a little bit of rationale behind the need for, I guess, training and all aspects of what I worked on. So rheumatic heart disease is the most common acquired form of cardiovascular disease in developing countries. And with limited screening, a lot of patients are just going about their lives, remaining in communities undiagnosed, and progressively, their valves and things get sicker. So in 2011, in the Gasabo district, which is this blue area right here, there was a screening done of school-age children, which showed a prevalence of about 6.8 per 1,000. In regard to that, there was another study, I think a few years before that, in Ghana, where the prevalence was only about 2 in 1,000, which it still doesn't seem that large, but I think just the greater burden kind of made the realization that we need some more community-based screening and earlier detection. So things that were already completed when I was able to be a part of this were a pre-implementation survey for our nurses in Kigali, as well as Team Heart leaders regarding the training. Cardiac business plan was created in 2017, and then the screening project proposal was sent to the Rwanda National Ethics Committee in 2019, and then all of this work is being done under a national umbrella, IRB. So the goals for our rheumatic heart disease screening is to identify children just in their early stages of the disease so that we can prevent, further progression. So it can help with having monthly prophylaxis programs and registering these children under, more of a national database. We want to increase the capacity of local healthcare providers with basic echo skills.
Hold on a second. I think we're both on call. No, I'm sorry. That was a mistake. Go ahead. I'm sorry,
Oh, no
Amanda.
problem.
Someone was at the door.
No problem. If anybody has any questions or anything too, like I can totally chime in, ask away. But so yeah, just moving forward, there are a lot of goals that we're working for, and creating an online forum is kind of where our trajectory went over this 2020 year because everybody was separate. So our main goal was to make an online education forum where we can have quizzes and mentor and just like follow along with these nurses, and to make it a sustainable project. So overall, our hypothesis was that integrated, self-paced, and mentored education modules will build the capacity for local healthcare providers in Rwanda districts to accurately screen and identify children in the early stages of RHD, while secondary prevention can still impact the need for surgical intervention. So the process of getting to this online module, online course, was definitely a hefty one. I think a lot of troubles that we found ourselves in were things related to Wi-Fi availability, access to by the nurses, as well as like our team here and in the Team Heart kind of Capitol building or whatever, their research department. We landed on creating a Google Classroom, which is accessible via Wi-Fi, and you can also download aspects to be accessed remotely, so not on Wi-Fi. We worked very closely with gathering information on basic echo screening. So David Adams was a wonderful help over at Duke, and he kind of helped us monitor or create these about 4 PowerPoints, about 4 classes that go through basic echo and then kind of what you're looking for with RHD and what you should be seeing. So then with that, with all those PowerPoints, we were able to translate them with the help of Oliver into Kinyarwanda, as well as upload them and implement them with transcripts written out in both English and Kinyarwanda on our Google Classroom site. So we were able to insert this information on each of the classes. So one is just like rheumatic heart disease in general kind of information, and then moving on to echo, and there's like about 4 others that I mentioned on here that I didn't take a screenshot of. So having all that information in one spot has been very helpful, and getting a location that is accessible here as well as in Rwanda was obviously our highest priority. And this is just another information. So when they click on the basics, they have access to these YouTube videos, which is the PowerPoints being read by David, who walks through, how to do the echo, as well as what it means and what the nurses are seeing. And then the transcripts written out in both English and Kinyarwanda. So again, just a few barriers about this in general is that the initial training was actually meant to be in person last May with a whole team traveling down there, and we were going to do the initial training and see how well it was received with the nurses, and then plan to separate them into different districts and like do full screening of about 20,000 children, both at school and in community centers. So this was definitely a hard turn that we had to kind of decide, okay, how can we still make something? And I think came out to be even better in the fact that it's sustainable, that we have it in one location, and that we'll be able to grow with it and ensure that nurses are able to get this information for years to come. Wi-Fi and data access was also an issue, just thinking about speaking with our colleagues over Zoom and our nurses over Zoom. It was definitely difficult with access, as well as just timing, because we were here and they were in Rwanda. And then the different platform options kind of made my head spin for a long time, thinking of the best way. So we had Wiki, Wix, Coursera, all these different options. Some of them were very expensive. Some of them were free, but not conducive to what we wanted. So yeah, we landed on using Google Classroom as an easy way to at least have all of our information in one spot. So at this moment, we've been able to complete our training modules, our PowerPoints, voiceovers, translation, and embedment into the Google Classroom. We've been able to partner with Philips Lumify and get about 6 Echo probes, which can be plugged into, I think, both iPhone and Android devices. And then moving forward, so this upcoming summer, the plan right now is to complete the training modules with our nurses. We have about 19 in our program or in the study arm that we want to conduct, which can be now either a combo of virtual and in person, depending on what works best, I guess, when summer comes. And then moving forward, we'll have 19 nurses. We'll split them into the Karangi and Hui districts, A and B, and our goal is to screen about 20,000 school-age children and, you know, gather that data and work towards then creating more penicillin prophylaxis and seeing what the need actually is. And then I just wanted to mention one other thing that I put a lot of my heart into over this summer, which was our Team Heart electronic medical record. So in Kigali, at the Team Heart station, there's a lot of paper and random Excel sheets of information of patients that we've had in the past. They're like INR follow-ups are on different sheets, which just, you know, in general, as we can understand, makes it difficult to follow patients. So our goal was to establish an online accessible registry to transfer all that information and have it in one local spot. So right now we have about 200 patients who have received cardiac care, whether that be surgery, which is mostly surgery, and just medicine and stuff like that. And we wanted to put it all in one spot. So we were able to create these, excuse me, these Google or these sheets that have all the information that we want to collect from our patients moving forward and from past that we've seen. And so we created each of these documents here. There's a few more, but I just had to include a few pictures so you can kind of see. And then the main thing that all of a sudden I think I became an IT lady over the summer, which was such an experience. We created a separate REDCap. So those of you that don't know or do know, that REDCap is a very wonderful place to have accessible information, and you can do data research and analysis from that information in there. So unfortunately, working with Team Heart in Rwanda, we weren't able to use the REDCap that we have accessible here at CU. So I had to create a whole database through Microsoft Azure, and like this whole SendGrid. Honestly, the words sometimes that I'm saying don't still make sense to me, but the point was to make our own space on the web to have the accessible authentication and like HIPAA compliant REDCap that now Team Heart can access with logins. And the next steps, I guess, are to put all those sheets that I previously showed you into REDCap that then the nurses, healthcare providers can just fill out as they go. So that's kind of a summary of what I was up to over the summer. And all in all, just a huge thank you to so many people. This list could probably be 5 pages long, but definitely thank you to the Global Chess Initiative Scholarship for making, you know, this possible and still make me feel like I can do something important over the summer, even though I was stuck pretty much in this apartment. But I really appreciate all of your time, and please let me know if you have any questions.
Thanks so much, Amanda. That was great. I want to give a special shout out to PK, because PK's initial global chest initiative was for asthma or pulmonary conditions. And he was very flexible. And we all know it's all about cardiopulmonary, right? So PK was willing to be flexible and expand and fund your project. And it was a little bit late in terms of getting funding for your project, because we had to work out the flexibility, but that was PK, and you have PK to thank.
Yeah, I appreciate so much.
And so I'd like PK to make some comments, and then I'd like Cal to make some comments because he has extensive experience in Rwanda starting their family medicine program. So PK, would you lead it off? I know we're a little late, but we'll only be a few minutes over.
Yeah, just take a few. First of all, let me congratulate you for this excellent work you're doing in Rwanda. I am from India, so I'm very, very familiar with the havoc rheumatic heart disease plays a role. When I was a medical student, it was just rampant. Now it's much better. And so, as Stephen was saying, we were basically involved with asthma, allergy, and some related disorders, but I'm very happy that we are involved with this work with rheumatic heart disease in Rwanda. With the type of work you're doing, I am sure we will continue to support you. It's very, very impressive work. Thank you so much for doing this type of service to the children of Rwanda. I congratulate you. Thank you.
So much. Thank you. Appreciate it.
And I want to thank you also for getting involved in this. I suspect that over the course of the year, you got a good idea of the scope of all of this and what this might mean for your career. I know Chip and Sia Bowman quite well, and we've actually done quite a bit of conversing together about this whole project. The thing that I think is notable here is that they have a very clear vision of sustainably improving cardiac health in children in that country. They don't just drop in and do a few surgeries and then leave. They have committed themselves over many years actually to work on this, and I think what you have been able to contribute to is some of the ongoing necessary measures to really make this sustainable and to put this into the hands of the Rwandans themselves. That I think is one of the principles of global health that we are all trying to promote. And I just want to thank you for being part of that. One question I asked, you mentioned a couple of times, you sort of gave clues as to what your role was in all of this. Could you maybe just explain that a little bit further? How did you personally get involved in this?
Sure. I think to put it like broad spectrum, I think I was definitely kind of a punching bag. I don't know if that's the best way to put it, but I think I was considered kind of an intern with Team Heart over the summer. So with projects that they were needing to move forward, they were like, hey, Amanda, are you able to reach out to this person and reach out to this person and kind of organize that so we can have that done in the next 2 weeks? So that's where I reached out to David and kind of worked with him on making sure that we had, all those PowerPoints done at a certain time, and then reaching out to Oliver, our translator, who was able to do that. So I think I kind of was like the centerpiece that was reaching out to all these projects to make sure that they didn't like fizzle out over the summer, whereas we would have been more in person and I would have been like at the Team Heart Center. And then for the Red Cap, so for the online thing, a lot of that was calling Microsoft. We had to apply for a grant to get Microsoft Azure, like their database, to have that yearly. So we were actually able to apply for that grant, which was for an NGO. So I think, yeah, a lot of it was just organizing and making sure that the projects didn't stalemate over the summer when everything kind of could have.
Well, I appreciate you saying that, because it may seem perhaps not quite as glamorous as certainly being there in person, or even being part of this team. But the bottom line is, I think that what you've been involved in is extremely important for the longevity of this program. And I'm not sure what your long-term plans are, but I would really encourage you to continue to work with them. And I think you're going to begin to see some of the results of this this work that you've done.
Thank you. Yeah, I definitely kind of have decided I'm in it for the long haul with Team Heart. So I'm excited to see what happens in the future. So
Yeah, thank you.
thank you so much.
Well, I just want to thank Dr. Berman for being so willing to reach out to all our amazing funders to make this happen for you guys. So thank you so much, Steve. Thank you, Dr. Wilson, Dr. Vedanthan. Thank you so much, Peter, and everybody who supported our students.
And thank you, Madiha. You've been such a supportive, terrific mentor for these students. And I know that you functioned in many cases as the mentor and facilitator. So you've really made it happen. And we're a great team.
Yeah,
well, thank you once again to all of the students. I think that you make our work so meaningful because by facilitating the opportunities that have been given to you, we can see how much it means, and both in terms of your career growth and personal growth. So thanks so much for coming through for us once again. We're in the process of trying to line up the Rotary clubs. I think that Peter and Cal and PK, I feel confident, and without putting you directly on the spot, but we sent out an email to make sure that you're willing to fund this next crop, and we're going to send these the recording of this to all of the Rotary clubs to see if we can get back to the 11 or 12 scholarships. And if we do, it's in no small part because of the really terrific job that all of you did this past year. So thanks. Madiha, do you have anything that you'd like to say before we close this down?
No, just congratulating the students on amazing work and all their achievements. And once more, thank you so much, Dr. Berman, and everybody who supported our students, all
Thank
our
you.
amazing
Great.
funders.
Thank you again.
Thank you all so much.
Take care, everyone.
Yeah.
Have a great week.
And just a quick note, I want to thank Desi, who stepped in and during, difficult times for a lot of different reasons. She really helped put this together, and thank you, Desi.
Thanks, Desi.
My pleasure. Thank you.
Okay, take care, everyone.
Bye.
Hi, everyone. Thank
Bye.
you.
Bye-bye.